So I have no disclosures. Today we're going to talk about a little bit just briefly about volume, but the majority of our time we're going to be talking about the data. We're going to try to make a sense of the mess of the MAS results in rectal cancer. And then as a surgeon, what do you have to think about in terms of a poor TME, the total mesorectal excision? What are the risk factors? Some new thoughts on chemo and radiation therapy. How might we avoid radiotherapy? And then for referral or for your own practice, what do you do about that lateral pelvic lymph node that you see on MRI? So does volume matter? Yeah, volume does matter. I mean, anyone in this room knows that if you do more things more often, you're going to be better at them. And what's really required? Well, it's not even that high of a volume. In this study of the NCDB, more than 12 rectal resections a year led to better lymph node harvest, lower margin positivity, and improved 30 and 90-day overall mortality. So what about the data making sense of this mess? And there's a lot of data. And this has been like a bad relationship over about 10 years. Classic trial, color trial, Korean trial, the ACOSOG trials, the Alucard trial. And then the one highlighted is the ROLAR trial, which looked at robotics versus laparoscopic. So the classic trial, we all got worried because right down the bottom, CRM, positive circumferential margin rates in low anterior resections were higher, although not statistically higher, in laparoscopic patients. The good news is at 5 years, there was no difference in local recurrence rates or overall survival, disease-free survival between the two groups. So what we found as a surrogate marker of quality really never manifested itself as true quality for the patient. Now the color trial, I'm just going to identify some of the discrepancies between these trials. In very low cancers, in the color 2 trial, actually circumferential margin positivity rates were higher in open surgery. So maybe laparoscopic surgery is better for very distal tumors. And as you can see, the local recurrence rates were actually higher in open surgery. Yet again, in stage 3 disease, disease-free survival was actually better in laparoscopic surgery. So maybe we don't have to worry. And then there's the American trial, which, again, I'm an author of both of these studies. Unfortunately demonstrated when we combined the surrogate pathological markers of quality together, we found that